Dear Professor Jakob, you are the head of sarcoma surgery at the Sarcoma Center in Mannheim, and today we want to talk to you about the best ways to perform operations on soft tissue sarcomas. Soft tissue sarcomas are indeed a very, very large group, and each operation is certainly quite different from the other, right?
Yes, not every surgery, but we do operate in many locations and perform various surgeries at the same location. Perhaps location is not the perfect word. Let's say localization. But even if you operate on the arm or the leg or in the abdominal cavity, the differences between the operations are still very significant.
And people come to you when all the diagnostics are already done. That means you have all the imaging and diagnostics done. You will only be involved once it is clear what type of soft tissue sarcoma it is, as well as its size and location. Is that right?
No, we're much earlier involved. Actually, one of the strengths of the center here is that we have a joint consultation and also see all new patients together. If someone comes in with a space-demanding lesion, they come into this consultation and they see one of us, mainly the surgeons on site. Because unlike other tumor diseases where you always have a counterpart, for example, visceral surgery and gastroenterology, in sarcoma surgery you do have a counterpart, but very rarely for the diagnostics themselves. For example, many of the sonographically guided biopsies that we perform when someone comes with a space-demanding lesion are simply done by the surgeon here.
We had talked about the diagnostics with Dr. Menge, and there was also this question. What about the biopsy channel? That it's very important for the surgeon to know this. It's handy if you do it yourself, because you'll know exactly where the channel is.
Exactly. Firstly, you know where the channel is. That's the first thing. The second is that during these biopsies, we always use a protective sheath for the channel. We call it a coaxial needle. It is always put in place, and the actual biopsy needle is used through it. This means that the tissue in between is already protected during the biopsy. That's one thing. And the second thing is we always make a small incision, so that the needle can be inserted well on one hand, but also so that we can recognize the spot where we went. This means there is a very small scar, and then we know that we need to cut it out later with a certain safety margin. And when we do the biopsies ourselves, we know that we always do them in the way where we can later excise it.
We've really dived deep into this topic now. But I think an important message we also wanted to convey is that you should definitely get treated at a sarcoma center, especially by surgeons. I believe it's very important not to go to just any surgeon with some experience, but to truly see experienced sarcoma surgeons.
That's right. I always approach it a bit differently in the sense that I say the experience naturally comes from the fact that we always see the bad things from other centers. So if I now say that one should not have surgery at another hospital, that's not entirely correct, because the patients who have been successfully treated there and are then tumor-free and don't come to the Sarcoma Center, they've been treated very well there, and there are quite a few of them. So, the colleagues who are not at the Sarcoma Center, let me put it casually, they are not idiots. They all studied medicine, completed a specialist training, and are doing a responsible job. But there are areas where one needs to have specialized knowledge, just like in many other things. And it's the same with soft tissue space-occupying lesions, where one would say, when the trauma surgeon sees someone after an accident with a large bruise, will he ask whether the trauma is adequate? So, did it really hit hard? Or he will ask whether the patient was on blood thinners, which would explain why the bruise is so large, and will then say, okay, I can say I am going to remove this bruise. And then that's a reasonable decision. If you now find out that someone says, oh, that's a big bruise. However, there is no trauma, meaning no accident and no blood thinning. But there is a large swelling, and it looks kind of strange. Then maybe he shouldn't operate on it.
Because then it's not a bruise at all, is it?
Exactly, because maybe it's not one. And those are warning signals that most colleagues do pay attention to. And that's why, from the outside, we always only see the bad things, where it wasn't taken into account, and that's always the problem. That's why it's fundamentally correct that, at the latest, when the diagnosis of sarcoma is made, you should go to the center. If there is suspicion, then as well. The English have actually established a good rule in the national health system, that they said the general practitioner can refer someone to the Sarcoma Center if there is a mass over 5 centimeters in size, if it has grown, if it is not just directly under the skin like a simple lipoma, and if the patient has discomfort. And that is a good rule of thumb.
Okay. And now we had already briefly talked about the tumor board and that the most important colleagues come together to discuss it. Are there situations where a sarcoma is simply operated on, operation, out, done, and everything is good?
That's not so uncommon. So, for example, there are a number of well-differentiated liposarcomas, and here we notice 2 terms. A sarcoma almost always has a first name, like liposarcoma, so the first part of the name. Lipo, in this case, stands for a fat tissue tumor, and sarcoma then refers to all the tumors. And here we have a second term, namely well-differentiated, and we call that grading, which means we assess the aggressiveness of the tumors. And then you would say, well-differentiated belongs to the tumors that can recur at the site of the event, on the leg, on the arm, wherever, but they have a low tendency to form metastases. And with these tumors, if they still have, let's say, acceptable local aggressiveness, you can also just operate.
Acceptable means that the likelihood of it coming back is not very high?
Exactly. So we would say, with a well-differentiated liposarcoma, the likelihood of tumor recurrence in the leg is 5%. Then you can talk to the patient. Do we want to try to make this recurrence rate even smaller? Then you could additionally irradiate it. Then it might be 2 or 3%. But that also means that we have irradiated the 95 other patients who do not experience a tumor recurrence, I would say, unnecessarily. And they might have side effects. And that can be openly discussed with the patient when making a treatment plan in advance. And many patients then choose either for a bit more security or they decide to say, you know, if 95 are irradiated for nothing, then we won't do that now. And that is a rational decision, but you can make it beforehand.
All right. Good to know.
And there are clearly other tumors, for example, ones that are more in the area of the skin or where the boundary layer between the fatty tissue and the muscles lies. That is, the so-called fascia. These are, for example, myxofibrosarcomas. This, for example, is a tumor that grows aggressively. We know that if we only operate on it, we'll have many patients with local recurrences. Even if we maintain a safety margin, we know that this seems to be a tumor where individual cells have apparently migrated further, resembling an infiltrative growth. And even if we maintain a distance, it is also necessary to radiate an area to kill these individual cells so that no recurrence occurs.
There is the option of first performing surgery and then doing radiation or chemotherapy. But there is also the other option, I think it is called neoadjuvant, where you perform radiation or chemotherapy before surgery. How does one decide between the two? When is one approach used and not the other?
So there is this one thing where you would definitely do it. Here comes a name again. Myxoid liposarcoma. This is a tumor that is very interesting, both in what we see visually on the MRI images, because it has a relatively typical appearance in the muscles. Then, at the same time, in pathology, he has very typical genetic changes, so the pathologist can identify him very accurately. So if you examine him genetically, not just under the microscope, but perform further investigations. And then there is a tumor that we know responds very well to radiation therapy. And now different aspects come together. When planning radiation therapy, a radiation therapist would need to explain this in more detail. But we sometimes do this together, so I can explain quite well. The radiation therapist looks at a tumor and says, "I can see the tumor now. Now I'll make a concrete plan by slightly enlarging the tumor volume that I see to have a safety margin, let's say up to here. And of course, this can be easily accomplished while the tumor is still there, because they can see it in the images. If we say now, this has been operated on and you only have a scar tissue afterwards, you might say, well, I think the tumor was somewhere around here and I also see scar changes, but very likely I will have to enlarge the size of my radiation field. So the radiation field will simply become larger. That is the first thing. So it simply gets bigger, the radiation field. That's the first thing. And the second thing is, the radiotherapists always increase the dose when they irradiate after an operation. Both cause more radiation side effects. Dose increased, field enlarged, more radiotherapy side effects. That is one aspect of preoperative radiation. Now, one might say, why not irradiate everyone preoperatively? We will address that shortly. But especially in marking, if you have already marked one and you can treat it well, then it might also get smaller. And, for example, this is the classic scenario with myxoid liposarcoma. You can see the tumor, you can distinguish it very well. It responds well to radiation therapy and should therefore be irradiated before surgery. In this specific case, you can also slightly reduce the dose, but that goes into a lot of detail.
But there are also disadvantages, right? If you irradiate beforehand, right?
Exactly. There are always two sides of the coin, and it depends on where you operate and has to do with whether wounds heal well or not. If you have irradiated beforehand, you increase the risk of wound healing disorders. Irradiated skin or tissue heals worse than non-irradiated skin, and that is a decision you must make together with the patients. However, as I said, there are tumors like myxoid liposarcoma I would always irradiate beforehand. And there are others where we would say, do we have a patient with, for example, long-standing diabetes, who might also be smoking, thus having a high risk of wound healing complications? I think very carefully. Do I want to operate on him first to ensure healing? Guaranteeing is always difficult. Create the best possible conditions for wound healing, and then it will be radiated. Then you accept that.
What is ultimately the goal of a soft tissue sarcoma operation?
The goal of the soft tissue sarcoma operation is primarily to make the patient tumor-free. In other words, to simply remove the tumor and at the same time ensure that the patient leaves the hospital on two legs in a reasonable condition as quickly as possible.
That sounds like a very good plan.
This is really important. It's crucial to weigh both things against each other. It has something to do with previous treatments, but also with the management of what you do there and sometimes with discussions with patients, like how radically you operate or not. Basically, we actually want the patient to not spend much time in the hospital.
Now there is always, so to speak, the technical jargon, and this so-called R0 resection is mentioned. What does that mean?
Yeah, so with R you can just translate that as margin. Let's say resection margin or tumor margin. In the end, it is classified. If we have a tumor and we have operated, then the boundary layer where we operated is specifically examined by the pathologist. Everything that we remove from the patient is sent from the operating room to pathology. This means that each specimen is examined. What you also have to know is that each preparation must also be kept for 10 years, at least parts of it at the very least. The pathologist takes parts of the sample from the middle, from the edge, and from very specific spots that catch his attention. They are embedded in wax, sliced into sections, placed on slides, and then examined. And then they are archived later. And this archiving is very important, especially for sarcoma patients, because honestly, even a pathologist, even if well-trained and careful, can still make a mistake. First, we might later prefer a different diagnosis. Second, there are indeed further developments, or sometimes we need additional medications to, for example, compare a new tumor manifestation.
Oh, so whether that's something entirely new or if it's really a recurrence.
Sometimes there is the question, can we go back to the old preparations to see if we have a second tumor here or a recurrence of it? And the third thing is, sometimes there are new therapy options, and then they are rarely dependent on what kind of tumor we have and what its characteristics are, or which molecules in the tumor are altered. And then you can go back to the samples and re-examine them. But that's very important.
Now, you explained what R0 means, but there are also R1, R2, and I think Rx.
Exactly.
What does that mean?
There are all three terms. R is the resection margin as judged by the pathologist. So, as I said, a pathologist examines exactly this boundary layer between the surgical specimen and the tumor. He looks, how far is the distance there? Then he makes a cut through, has it in the specimen, and then he looks under the microscope. How far has the tumor grown, and is there still a layer of healthy tissue? And it can also be narrow. And when he sees a layer of healthy tissue towards the edge, he says, that is R0. There is no tumor there. And now there is the second situation where he says, well, I can see that there are tumor cells at the edge of my microscopic preparation. However, it seems to me that the colleague in surgery did not cut through the tumor.
So like roughly through the middle or something.
Exactly. That means, if you imagine it like this, the tumor extends up to this point and the specimen ends at the boundary layer. Then the pathologist would say, I'm not sure at this point if you have completely removed it, because I see tumor cells at the boundary layer. Then he says, this is R1. And then there are indeed situations where he sees that the tumor has simply grown. The cut made by the surgeon, which can be seen in the specimen, simply goes through the tumor. One must assume that some tumor remains. That is one classification. Or one says, I see this tumor has been ruptured. It was injured during the operation. You can see that. Imagine you have a balloon or a ball and you notice it's torn at the top. Then you say, the tumor has a rupture. It's broken open. And you must assume that tumor cells are still left.
And this happens because, for example, it couldn't be seen clearly on the imaging, right?
There are many reasons why this can happen. It might simply be that although you've operated carefully, tumors can be very fragile. Especially when you have large tumors, it can actually be the case that during an operation, just by mechanical manipulation, a tumor can simply tear. That can happen sometimes. It shouldn't happen often, but someone who frequently operates on tumors, no one will deny that this hasn't happened to them too. It can simply be that you have a large, soft tumor, you do your best, and at one point, you just exerted a little too much mechanical force, and then it tore there. And that's R2.
And what is Rx then?
Rx is when the colleague can't really say it properly. So that's where everyone hesitates a bit and can't say, is it complete or not? There can be situations where the specimen is removed, but there is still some tumor visible at the boundary layer, and the colleague says, I have operated further, sends in a second specimen, but it cannot be easily attributed, and then the pathologist often steps back and says, I cannot assess it precisely. It is Rx.
And if you now have R1, R2, or Rx, what can you do then? Do you have to do chemotherapy or have another surgery, or what can you do then?
Then you need to think first. You have to check. Where was the tumor? How is the patient doing? Is everything healed? How long ago was that? So can I still go there or not? And then, actually, what options do I have at this point? I remember individual cases where we surprisingly had an R2 resection. For example, because a tumor had grown into blood vessels, which we did not see in the images. And we cut through these vessels under the assumption that no tumor would grow further, and the pathologist tells us, Look, at this point it has grown into the vessel. That's not acceptable. And in such a case, we might say, I'm going back to the OR. You find this out quite early, so the wounds are still in a state where they can be easily reopened. You have to explain that well to the patient.
So, within days, or how should I imagine
You
that?
usually get this done within a week.
Yeah, okay.
You usually get a resection status and such a statement within 1 week to 10 days, and then we would go back to the operating room and say we are going to operate on this spot again. Of course, you have slightly worsened the overall result because you simply cut through the tumor at a small spot. On the other hand, you removed everything afterward. That would be one approach, for example.
Following this, I presume chemotherapy will be prescribed, correct?
The question is whether you might have done one before or not, whether you did radiation therapy before or not. That's what I mean by the options you have. For example, if you have someone in such a position whom you have not yet irradiated, then you would definitely irradiate them afterwards. It depends. You simply need to discuss it with each other. More often, the situation is that someone comes to us with a previous R1 or R2 resection.
Oh, so that's what we talked about at the beginning.
Exactly. Those are, let's say bluntly, the bad ones, where you have to consider, what do I do with them? And indeed, it is the case that we reoperate on many of them, but not on some. And that also depends on the possibilities. So if I have, for example, a spot that I can reach well surgically, where I can say I can redo it very well in order to achieve high safety for you while preserving good function, then I always suggest to the patient, let's please redo it. There are critical points where you have to say, if I operate on that exact spot again, you will lose a nerve, a function, important muscle groups, or I will have to touch the bone. If we are not entirely sure whether it will actually regenerate at that spot, then we wait. Or if it was R1, then we say, let's do a postoperative radiation therapy at that spot. And then we accept a slightly worse outcome but preserve the function as it is now. So it's simply an individual decision.
So that means you really have this discussion with the patient, weighing up functionality, preservation, and so on.
Yes, I have to discuss this with the patient.
And where the patient is basically asked, or also put in the position to decide what is more important to him. So to speak, a few more % safety now, or a loss of functionality.
Yes. So it's very clear, for example, with those tight margins near a nerve or a vessel, where we might have to replace a vessel, where he might need more blood thinning, has a higher surgical risk, more bleeding risk, or where we say, it might also be the case that we can operate closely along the vessel. But then we have a higher risk of the tumor coming back here. However, we have already done radiation therapy here before. Personally, I consider the risk acceptable, or if you want higher security, then we have a higher surgery risk, and we just need to discuss this together.
That's good that it's possible, isn't it?
Yes, it is possible if you plan well.
Yes. Now, we have talked a lot about the tumor, but often, at least with many other types of cancer, they tend to use the lymphatic pathways to send their malignant cells further. Is it the same with sarcomas?
In rare cases, yes, but in most cases, no.
Oh, really? Okay.
There are typical tumors where lymph nodes are closely monitored. Well-known examples include melanoma, which often spreads to the lymph nodes, or when colon cancer is involved. This does not apply to most sarcomas.
It depends on the type of sarcoma whether that is important or not. That means, in general, you also do not operate on them.
Generally, we just examine it clinically. So if we know it's a liposarcoma, for example, then we'd say, I'll feel for it in the groin and take a look, but I won't do a specialized examination for it because the likelihood of lymph node metastases is very, very low. And then I really don't need to do that.
We already talked about it, but it is certainly an important point again to consider where the soft tissue sarcoma is located, whether it's in the extremities, in the abdominal cavity, or where else could it be? How does the operation or your approach differ in such cases?
So, first of all, it clearly differs in the approach. So, when you operate on the arm or leg, you can easily imagine taking a direct route there. That you wouldn't operate on a tumor that's located, so to speak, on the backside of the arm from the front, from the other side. Yes, it makes sense immediately. It's relative logic. In the abdomen, it doesn't work that way at all.
Oh, I see.
We have many tumors, so to speak, in the retroperitoneum, which is the rear abdominal cavity. If you imagine someone having a kidney colic, it hurts back here, and it hurts back here because the kidneys are located further back, while, for example, the intestines or the liver are much more forward. Retroperitoneum, rear abdominal cavity, but you would not operate from the back. They operate from the front. And the reason for that is they can do it much better that way. If they had to operate from the back, they would have to destroy so much of the musculature and, let's say, musculoskeletal structures to get there that it would simply be unacceptable. And you still wouldn't have an overview. So, first the access route, a completely different access route, and then it's much harder to maintain distances in the abdominal cavity or retroperitoneum. Because, of course, when you have a large muscle group like in the thigh, which is several centimeters thick, and the tumor is on one side, you can always say, I maintain a safety distance of 1 or 2 centimeters, let's say. And there is always enough left on the other side. If you imagine it in the abdomen and draw a circle of 2 centimeters around a tumor, you may end up removing 2 to 3 vital organs, plus the corresponding vessels lying next to it, resulting in an incredibly restrictive and dangerous operation. That's just not possible.
So, to my understanding again, with muscles, it's like this. If I cut away a piece of the muscle, the other piece that remains still works. But if I have an organ and I wanted to cut a piece away, that wouldn't work at all because I would destroy the organ that way.
That may well be, but the risks are quite different. So even if I take more muscle in that muscle, for example, it may be that a patient needs an aid, walks worse, but in most cases, he will survive. And then it's like people say, we need to work on the function, and that can also make big limitations. I'm not saying that's good, but in the gut, it's like it can be dangerous. For instance, if you operate near the vessels and the pancreas at the same time, it can lead to the patient having life-threatening bleeding frequently. Then you might lose the patient, which is not the goal of the operation.
And what about the throat and head? There are also sarcomas that can occur.
There are also sarcomas. The patient's pathways often differ because ear, nose, and throat doctors, who often operate in this area, operate on many other tumors but also do a lot of diagnostics themselves. And there's the tendency for an ear, nose, and throat doctor to operate with an approach that's actually adapted for a carcinoma. It seems very logical to them. That's one thing. This means the patient pathways are often different. There, an ear, nose, and throat doctor frequently operates on a tumor, and the patient then comes to the Sarcoma Center. That does not necessarily mean that the operation was bad. That just means that maybe the coordinated approach will happen only after the operation. The second thing is, in the head and neck area, we actually have a similar problem as we often do in the abdominal area. Imagine the artery to the head or the larynx, or the connection between the pharynx and the esophagus. This means if there are tumors there, of course, they are limited in terms of what we can operate on. And that makes a big difference in the approach. So the location determines what you can do and what you can ask of a patient. When I said earlier that we look at a single vessel or nerve and discuss with the patient how we proceed, this also applies to abdominal surgeries. We usually have an idea of what we can expect from most patients, and there are standards for that. So, in the belly area, we simply come to shorter distances that we need to plan better and say, where we can have distance to the abdominal wall, to the intestine, to the rear muscle that we include, we keep large distances, but we have to plan them very precisely where it becomes significantly more dangerous.
Understood. And if the operation is successful, how does it proceed after that? What is a typical progression? So I think we talked a bit about possibly further therapies, but what about rehabilitation, or what needs to be done?
For example, for patients who have undergone surgery on their arm or leg, we have a clear rule. The patients must be able to take care of themselves, or at least manage personal hygiene, and be able to move on a level surface like a ward floor or apartment level. The wound must be free of infection, and the pain must be manageable. This means that it is quite possible that patients may still be taking painkillers, but they must help, and help in such a way that they can manage in everyday life. And then we can send the patient home. But this does not mean that we discharge him from treatment. Instead, we often look at the wounds again 1 or 2 weeks later. So here, we have handled it in such a way that we often still see patients until the 3rd week to check on the wounds. And then we say, okay, up until then, they've mostly been at home. They get a prescription for physiotherapy so they can start with physiotherapy at home. Here we are already at the next step of care. For example, giving them a prescription for physical therapy. And then there is the next step. When we say the wound is healed, they have been to physical therapy, they are managing at home, then ideally, if no other therapy is planned, patients should go to rehab afterwards. So when we say radiation therapy, short break, surgery, healing process is okay, there should actually be rehabilitation for the patient to return to life. It is different when he is given radiation. We have to look at the wound and then say the wound is now fine. We refer the patient to the radiation therapist and the rehabilitation comes after that. Important for patients is that a strong anchor for applying for rehabilitation is the social service in the hospital after the operation.
But the patient doesn't have to think about that, right?
It's in our patient's plan, and the colleagues know that too. It always helps when patients think along and help out.
Yes, you are right.
Important note for relatives. Be considerate and support the team as well. That helps a lot.
And I think we haven't discussed an important point yet. I think many patients have problems with lymphedema afterwards. How can I influence the course of the entire therapy or later so that it gets better?
Yes, this is a clinically and scientifically very demanding topic, and honestly, it is something we struggle with a lot. For instance, we have many tumors when we consider the extremities, located in the thigh. And the access routes, especially if we imagine these adductors again, that's where the soccer player has the strain. So the muscles contract like that, then it's an area where the lymphatic vessels run from the foot. And if you operate there, you sever these lymphatic vessels. And it regularly takes quite a long time for this lymph to find other ways. And while that accumulates, that's one thing. The second thing is, the lymph can get into the wound, and sometimes we have almost oozing wounds due to the lymph. That's why we sometimes leave the drains in longer so that the skin heals well on the outside. The first thing you actually do in the operation is you often have to close lymph vessels, because they are simply functionally less important than the nerve and the skin there, and we simply have to perform a good operation to preserve these functions. I'm sorry, but it's often like that. And you can't easily transplant or reconstruct lymphatic vessels during surgery. It's not like a vascular bypass on a major artery that you can do. So we often have to accept a lymphedema. We just have to start treating it early enough. For example, in our operating room, the leg is often wrapped in compression bandages in most cases. That means there is no swelling, and it starts from the bottom to the top and over the wound. This means a large lymphedema cannot develop. When we are on the way to wound healing, we prescribe almost all patients a compression sock. Many people then ask, why do I need it? Then I say, because some of our patients would otherwise develop lymphatic swelling, and we want to prevent that. We want to maintain the lymphatic flow in other ways. It is an important measure. We also tell patients to go for lymphatic drainage after the wound has healed. It's important to inform people that wearing the stockings is important and simple so that they can adjust to it. In most cases, it's acceptable. In some cases, it is such that it is very stressful for patients. That's true, and in these cases, therapies are very difficult. There are a few specialized clinics for that. You can specifically send patients there. And in individual cases, you can also consider transplanting lymphatic vessels or lymph nodes to improve that. However, this is indeed a very difficult and demanding field.
Dear Professor Jakob, thank you very much for this really great overview on the subject of soft tissue sarcoma surgery. I believe this has really brought a lot of clarity about how it all works and how it all goes, and I am very sure that many patients will be very reassured by this. Thank you very much.
Thank you very much to you, and thank you to the patients for their trust, and we hope that many will see this.